Hey everybody, welcome to the class. I just wanted to take a quick minute to introduce myself and the topic of the class. The topic of the class is going to be Wolff Parkinson White, but it's going to be taught from an angle of teaching any local EMS providers who may encounter our son Aiden, who was born with Wolff Parkinson White. For anybody that doesn't know me, most importantly, I am Aiden's proud dad. My name's Mike. So Aiden's journey starts on a cold February night whenever we were sitting at home and his mother started to have some random fluid leaking. We weren't real sure what it was since it was 5 weeks before his due date and there was no gush like we were expecting when her water broke. We called the physician to seek guidance on how to proceed, and the physician advised to get to the hospital so that they could test and determine if it was amniotic fluid. Once at the hospital, they confirmed it was amniotic fluid and that she was indeed in labor. Nothing too exciting happened the first night except for some mild contractions. The next morning, after the spinal tap was in, was whenever they started the Pitocin. So now the big moment was finally here and he was on his way. The NICU team was present, however, he was born at 7 pounds 4 ounces and had an APGAR score of 9 at 1 minute postpartum. Labor and delivery handled postpartum care while the NICU team was cleared and sent back to their floor. 48 hours after delivery in the mom-baby unit, Aiden qualified for discharge in all categories, except that in 3 categories he was very close to not qualifying. Dr. Tattershaw with Akron Children's Hospital Primary Care decided to keep him for an extra day just to be safe. He was fussy, and on that 3rd day he was pretty much inconsolable. Whenever they took him for his routine vitals that night, the nurse came back into the room after an extended period and informed us that his heart rate was extremely fast and that he was sent down to the NICU. She advised that he was doing okay, but the neonatologist would be up shortly to fill us in. Obviously, this was pretty much the longest 10 or 20 minutes of our life, which it felt like 10 or 20 days. The neonatologist that was on, Dr. Kistler, came and advised they performed an RRT on Aiden, and they treated him with 3 rounds of adenosine and that he converted at 0.2 milligrams per kilogram. She informed us that they had sedated him while calling cardiology for consultation, and cardiology advised prior to electrical cardioversion they should try 0.2 milligrams per kilogram, and that is when he converted. So he had already been sedated with morphine and Versed whenever we got down to him, and after the day that he had, some sleep for all 3 of us was much welcomed. We were sitting in the NICU watching him through the wee hours of the morning when Dr. Vandicapelli arrived. Dr. Vandicapelli was with Akron Children's Hospital Cardiology Group. He diagnosed Aiden with Wolff Parkinson White presentation on ECG tracings, and he began treatment with propranolol. He also did an ultrasound, which found a mildly patent foramen ovale, which is not uncommon for children that age, he explained. The side effects of propranolol include bradycardia, apnea, and trouble with glucose. Fortunately, Aiden was not having trouble with glucose, however, he was triggering bradycardia alarms frequently and apnea alarms frequently. They kept him for several days after his last alarm to ensure a safe discharge and that he would be able to go home safely on propranolol. Aiden spent a total of 12 days in the hospital. After 12 long days, Aiden finally gets to go home. He says, "Sayonara, guys." Aiden is now home and doing very well, other than side effects of his medications that cause severe abdominal cramping. His propranolol gets titrated monthly based on his weight, and his first night home, he had a captured run of SVT that lasted about 40 seconds. He was asymptomatic throughout the event, and it was self-terminating. He has been back to the ER for SVT several times now. Sometimes whenever he has a run of SVT, we're able to get him to terminate through vagal maneuvers, and he doesn't have to go to the ER. Gagging and probing have always failed, but ice to the face has succeeded. We'll cover vagal maneuvers more in depth later on in the presentation. Here is Aiden wondering why they keep taking me to the place that likes to poke me with the needles all the time. Here's some of Aiden's proud battle scars, including his unicorn horn. This was his very first one. So first of all, just some terminology to agree on before we get into the class, just to make sure we're all on the same page with each other. Wolff Parkinson White presentation is a condition that can be diagnosed on ECG tracings. It is not an arrhythmia in and of itself. Wolff Parkinson White syndrome is whenever the patient with Wolff Parkinson White presentation experiences tachycardia. SVT or PSVT is an abnormal rhythm caused by abnormal electrical conditions such as Wolff Parkinson White. Sinus tachycardia is a way for the heart to compensate for abnormal conditions elsewhere in the body. SVT and sinus tachycardia are not the same and shouldn't be treated the same. Sinus tachycardia is usually a desired compensation technique when there's a need for increased blood circulation elsewhere in the body, and the rate itself should not be treated in that scenario. AFib RVR is a tachycardia with heightened ventricular response to a rapid misfiring of stimuli from across the atria. Depending on the reference book, AFib RVR can be looked at as technically a form of SVT, but it requires a different treatment, and for the purposes of this class, we will differentiate between SVT and AFib RVR. So what is a normal sinus rhythm? The electrical impulse originates in the SA node, which is here. It spreads evenly across the atrial chambers, as you can see here in purple. It gets to the AV junction, and only the AV junction, which is the path that it should be taking to the ventricles, as you can see here. The AV junction is the only spot that the electricity should pass through when going from the atria to the ventricles. It pauses in the AV junction, and during that time the ventricles are able to fill. After it pauses, it spreads evenly across the ventricles. The normal rate is 60 to 100 in adults, but babies can have much higher baseline rates. Here's just a chart showing you normal vital signs in a baby. As you can see, a neonate can have a heart rate as fast as 200 beats per minute whenever they're awake. At 1 month old to 1 year old, they can be up to 190 beats per minute. It's important to remember these are normal vital signs. So a patient like Aiden, who is treated with propranolol would typically not be at the higher end of this spectrum. So this is a nice video. It'll go through an electrical impulse several times and in slow motion so that you can see what the heart is doing at each phase of the EKG interpretation. And this is just a still shot if you would like a different look at it. Here's another picture of Aiden, or one of our first family photos. So accessory pathways are not normal parts of the heart's anatomy. However, some patients are born with electrical pathways, referred to as accessory pathways, that connect parts of the heart that aren't normally connected. The accessory pathway can actually cause the normal pathway to be completely bypassed. An accessory pathway can be congenital, meaning they were born with it, or it can form as a result of heart disease later on in life. This abnormal pathway is what forms the abnormal electrical circuit that can cause a cardiac arrhythmia. So these are the four most common types of cardiac arrhythmias that are classified as SVT. If you look at each rhythm, you can actually see which part of the heart has an accessory pathway connecting it. We're specifically looking at atrioventricular reentrant tachycardia for Aiden. If you break down the title of the arrhythmia, you can actually determine which part of the heart is connected. So for Aiden, his atrial chambers and his ventricular chambers have an abnormal pathway connecting them, causing at times a reentry tachycardia to occur. So as we said, whenever Aiden's heart enters SVT, he is said to have atrioventricular reentrant tachycardia, or AVRT. There are several varieties of AVRT, but the most well-known is from Wolff Parkinson White, which, as you know by now, is the condition that Aiden was born with. There's Aiden showing off his proud unicorn horn again. So the prevalence of Wolff Parkinson White. There are fewer than 20,000 new U.S. cases per year. The overall risk of sudden cardiac death in Wolff Parkinson White syndrome is estimated at 0.1% in asymptomatic patients and 0.3% in symptomatic patients per year. If you have 20,000 new cases, essentially 20 to 60 will result in sudden cardiac death. Between 7 and 20% of Wolff Parkinson White patients have structural issues as well, but fortunately, Aiden's echo was negative for any structural anomalies. Wolff Parkinson White is a congenital condition, and it is not developed or grown into or grown out of. People born with Wolff Parkinson White often have characteristic changes on their baseline ECG, most notably the delta wave. So we've established the AV junction pauses the electrical activity for a period of time. but the accessory pathway, called the bundle of Kent, that is present in Wolff Parkinson White allows for direct stimulation of the ventricles through that bundle of Kent. This will produce dual stimulation of the ventricles whenever the AV node conducts the electrical impulse appropriately. However, you have the bundle of Kent allowing for direct stimulation of the ventricles without a pause. So that's where you start to see that delta wave whenever you see the electricity coming across the heart in two different locations. The bundle of Kent, or the accessory pathway present in Wolff Parkinson White, can actually allow for transmission of electricity in both directions, which becomes very important whenever we talk about AVRT or any kind of reentrant tachycardia. The ability of the accessory pathway in Wolff Parkinson White to conduct electrical impulses from the atria into the ventricles is important for several reasons. This dual stimulation of the ventricles creates a distinguishing pattern on ECG, specifically a slurring of the QRS complex, which is referred to as a delta wave. By recognizing the presence of a delta wave on the ECG, a doctor can make a diagnosis of Wolff Parkinson White. So normally you would see a return to the isoelectric line for a period of time prior to the QRS, but what you notice here is it goes straight from the P wave into the QRS. This is because the accessory pathway causes dual stimulation of the ventricles. Essentially, that bit of electricity that goes through the bundle of Kent hits the ventricles before the main electricity that is traveling through the AV node, and that is what creates the pre-excitation wave, or the delta wave, where the QRS complex is kind of slurred going up. So you have that same picture here, but you can see where it should return to the isoelectric line, and you can also see where the QRS complex should begin, but it's this accessory pathway dual stimulation on the left that allows for the slurring of this QRS complex, creating the pre-excitation wave or the delta wave. So some of the research that I've done in looking into this indicates that some clinicians may confuse Wolff Parkinson White SVT with VTach. I would anticipate that some of this is from the fact that the delta wave makes the QRS appear somewhat wider than 0.12 seconds, and whenever they start to get into a tachycardic rhythm, it is often too fast to see P waves. Obviously, however, these are very different rhythms requiring very different treatments. So the pause at the AV node serves a very important purpose. It allows for a period of time after atrial contraction for the ventricles to fill before the electricity goes across the ventricles and causes them to contract. This creates some unique situations with a Wolff Parkinson White patient. Whenever they're not in SVT, there is some pre-excitation of the ventricles causing some mild contraction before they fully contract. That is because the electricity is coming through the accessory pathway and some of it is coming through the AV node. To better understand the correlation, that is why you see a slurred QRS or a delta wave. So with an accessory pathway present, you'll find issues with Frank Starling's law. Starling's law addresses the fact that the more blood you can fill on preload creates greater stretch in the ventricles, and it causes a more forceful contraction. So not only do you have less blood in the ventricle now from a shortened preload, but you will have less force because you have less stretch to eject that blood from the heart. And this is just an animated version of reentrant tachycardia. So SVT symptoms from Wolff Parkinson White syndrome. The symptoms that you're going to see in a patient in SVT due to Wolff Parkinson White will be no different than any other patient experiencing an extreme tachycardia. You might see shortness of breath, you might see chest pain, dizziness, you might see fatigue, the patient may be pale. Symptoms will last as long as the SVT is present. The symptoms stem from hypoperfusion secondary to decreased ventricular filling time. It would be important to understand that if you had a patient in AFib, the symptoms would be likely exacerbated if they were an AFib RVR and they were a Wolff Parkinson White patient as well. So general considerations for pre-hospital management of SVT include the decision of stay and play versus load and go. To determine that, you not only want to look at current stability of the patient, but the patient's ability to maintain their stability. One key factor that determines the patient's ability to maintain stability would be how long have they been in the arrhythmia. Do you know exactly when the arrhythmia started? Or is it a scenario like with Aiden where he gets his heart checked 4 times a day and may have been in this rhythm anywhere from 1 minute to 6 hours? Other general considerations would be whether you should be obtaining IV access or IO access. Obtaining access on a patient in SVT should be a top priority even if you feel the patient is stable and you feel more comfortable waiting to get to the ER to push adenosine. Obtaining vascular access is on the list of things for us to accomplish, always, with a patient in SVT. The consideration for IO access should be present if and only if you absolutely need to push a medication to maintain that patient until you get to the hospital. The thing that you need to consider with IO access is the risk of complications such as osteomyelitis versus the need for immediate vascular access to push a life-saving medication. So essentially, does that patient have time to get to the ER and get intravenous access using either ultrasound or an IR vein finder light, or do you think that the patient is going to decompensate and crash any second? The nice thing with obtaining peripheral access is it can be a twofold treatment. Generally, pain increases the likelihood that the patient is going to bear down and stimulate the vagus nerve, but it also allows for the actual intent of obtaining vascular access. Another issue with pediatric patients is having a system for precise dosing. At the end of the video, we will discuss one system of many available for precise dosing of small amounts of medications. So before we get into specific BLS and PALS interventions, I want to show a few clips from a quick video that will outline some of the drugs that we can use, and it's actually going to be focusing on the drug class. So to better understand how the medications we use work, here is a review of nodal action potentials in the heart, and we'll just get straight to that part of the video.
This is the action potential for a cardiac myocyte or a cardiac muscle cell. What about the nodal cells? Well, at first glance, you'll notice that the action potential for the nodal cell looks a lot different than the non-nodal cell action potential. For one thing, you don't have phase 1 or phase 2. All you have is phase 0, phase 3, which is, again, your repolarization phase, and phase 4. Now let's talk about what's going on in this action potential. So in phase 4, we have this slow rise in voltage because of open sodium channels. And at the tail end of the phase 4 period, calcium channels start opening. We hit threshold and a bunch of calcium channels open, and we get this large spike in voltage. This is phase 0, and again, this is because calcium channels are opening. There's no phase 1 and phase 2, so we go automatically into phase 3, which is this repolarization phase. And this is mediated by a bunch of opening potassium channels. And eventually we're back down to phase 4, where we have the sodium channels again, opening slowly. So again, these two action potentials not only look different because there's no phase 1 and phase 2 in the nodal action potential, different ion channels are open during different phases. Another important piece Okay, so let's talk about class 4 antiarrhythmics. And these are your calcium channel blockers. Calcium channel blockers come in two types. You have your dihydropyridine, which is abbreviated DHP for short. And you have your non-dihydropyridine calcium channel blockers. Your non-dihydropyridine calcium channel blockers work at your SA and your AV nodes. So they work at the heart. Where your dihydropyridine calcium channel blockers, these work at blood vessels. Sometimes to remember this, I will erase this O and I'll draw in a heart in place of the O so that I remember that the non-dihydropyridine calcium channel blockers work at the heart. And again, the dihydropyridine calcium channel blockers, these work at blood vessels. They have little to no effect at the SA and AB node. So where in the nodal action potential are calcium channels important? Well, they're important at phase 0. So when you have a calcium channel on board, you're going to hit threshold just as fast, but it's going to take you longer to go through your phase 0. Therefore, you're going to decrease firing at the SA node because it's taking you longer to get through phase 0. So again, because we're decreasing or delaying the slope of the phase 0 period at the SA node, we're going to decrease firing at the SA node. Since they also work at the AV node, we're going to slow down conduction through the AV node. And again, both of these will lead to a slower heart rate. And since we're slowing heart rate, calcium channel blockers work great for SVTs. So the next class we're going to talk about are our class 2 antiarrhythmics. And these are beta blockers. Beta blockers work because they decrease sympathetic stimulation. They block the beta 1 receptors at the SA and the AV node. So I'm going to draw out a couple nodal action potentials. Now, how does sympathetics work to increase heart rate? Well, sympathetics work by increasing the slope of phase 4. So basically, you're hitting threshold sooner. And if you hit threshold sooner, you're going to have more frequent depolarizations. Okay, so I'm going to erase this so we can see how beta blockers work. Beta blockers work by blocking sympathetics. And if sympathetics increase your phase 4 slope, beta blockers are going to work by decreasing your phase 4 slope. So actually, it's going to take you longer to hit threshold. Once you hit threshold, the action potential will be the same, but it takes you longer to hit that threshold. So again, by decreasing the rise of phase 4, you're going to decrease the frequency of SA node firing. And since beta blockers work at the AV node as well, you're going to slow conduction through the AV node. So both of these things are going to work to decrease heart rate. And that's why beta blockers are great at treating SVTs. Again, like AFib and even atrial flutter. Beta blockers can also be used for ventricular tachycardias, also known as VTAC. So someone with a history of an SVT or VTAC might be put on a beta blocker to help control their heart rate.
So adenosine is a naturally occurring organic compound in the body, and it is given in a specific concentration for treating SVT. A potential side effect could be vasodilation, and although we're not giving it in SVT for the potassium channel activation, it can actually activate potassium channels. We use adenosine for its calcium channel blocking properties so that it slows conduction through the AV node. There should be strong consideration for all patients in SVT to receive supplemental oxygen while they're in the acute phase of care prior to breaking the arrhythmia. Our goal to intervene should focus around creating an AV node pause. This can be done through vagal maneuvers, AV nodal blocking medications, and synchronized cardioversion. In having the conversation with Aiden's cardiologist about ways to interrupt his SVT, he mentioned that vagal maneuvers are typically only effective in the first 15 minutes of the arrhythmia, so if you don't know how long they've been in the arrhythmia, it is definitely worth attempting a vagal maneuver while somebody else is establishing IV access or doing some other task. However, please understand that if you are past the 15-minute mark, the vagal maneuver may not be strong enough to interrupt the SVT. With Aiden, we have tried gagging him with a probe down his throat, and it has been unsuccessful. We have tried probing him in the rectum to try to get him to vagal out. You'll cause them to bear down, and that has also been unsuccessful. They're both very valid attempts to try. Just because they failed in the past does not mean they would not work in the future. Unfortunately, so far, the only response that we get from him is an awfully funny look whenever he kind of stares at us like, "What the heck are you guys doing?" We have been able to successfully convert him using a bag of ice to his face, where we essentially smothered him for about 10 seconds, although it felt like 120 seconds. We watched the monitor, and after about 10 seconds of him trying to fight, it caused him to bear down in the chest, and it converted him to a totally normal sinus rhythm. When this occurred, my wife heard it on a routine heart check at 9 o'clock before going to bed, so we woke him up, and he was completely asymptomatic and just thought it was time to play again. He did not get fussy until we started poking him and prodding him to get him to vagal out. My wife had the right idea, though. She stood back and got supplies while I was the one doing all of the annoying stuff to him. So if he gets a complex later in life where he hates one of us, it'll be me. So like we said earlier, adenosine is the medication of choice to create an AV nodal block to slow down conduction through the AV node and break the SVT. It's given at 0.1 milligrams per kilogram on the first attempt, and can be repeated at 0.2 milligrams per kilogram on the second attempt. Be aware of what your protocol currently says, as a third round of adenosine is used in some protocols and not in others, but it would be a third round, again at 0.2 milligrams per kilogram. Adenosine should be given with rapid IV push, followed by 10 to 20 mLs of rapid IV flush, to ensure the medication makes it to the heart before it is metabolized. So be familiar with your specific equipment. How I personally like to push the medication is utilizing a high port on the IV tubing for the saline flush, a low port on the tubing for the medication in 1 to 2 mLs, and the saline flush in 10 to 20 mLs. And I am pushing the saline at the same time as I am pushing the medication, so the saline flush pushes it to the heart in a rapid manner. When you are using adenosine or any other medication that is inhibiting electrolyte channels in the heart, You should have therapy pads on and connected to your cardiac monitor so that you are ready to defibrillate, pace, or cardiovert should the need arise. This becomes more important with a Wolff Parkinson White patient. A Wolff Parkinson White patient in SVT is appropriately treated with adenosine. However, a Wolff Parkinson White patient in AFib RVR could decompensate into VFib very rapidly. And we'll go over some of the differences later, but since it is incredibly hard to tell if a patient is in AFib RVR versus SVT at times, it is important that the therapy pads are in place and ready for immediate defibrillation. The fortunate thing is AFib is typically a result of heart disease, so it is unlikely for a pediatric patient like Aiden to ever be an AFib. If you get to the point where you need to immediately convert this patient, electrical synchronized cardioversion is an option. The most important thing to remember is to hit the sync button. Without synchronizing, you can create an R on T phenomenon, resulting in VFib. Electrical synchronized cardioversion for a pediatric patient typically starts at 0.5 to 1 joule per kilo. It can be repeated at 1 to 2 joules per kilo. A common general concept is to increase your joules with the second attempt so you are not trying the same effort that did not work the first time. This can be painful, and it probably would be, but if the resources are available, sedation should be considered, but should never delay cardioversion. That being said, cardioversion should not be done electively in the field, only whenever it needs done right now to prevent a pending drastic deterioration such as cardiac arrest. Additionally, IV fluid administration can be very beneficial for the patient that is experiencing symptoms of hypoperfusion, most protocols indicating 20 mL per kilogram. So patients that experience frequent episodes of SVT, patients that have extreme symptoms during those episodes, or have difficulty breaking those episodes, require definitive care. Long-term drug therapy is typically not completely effective and is not considered to be definitive care. Aiden is on beta blockers, and he experiences some benefit, but only until he is old enough to either let us know when he is having an episode or old enough to have an ablation. Long-term definitive care for Wolff Parkinson White in symptomatic patients is a cardiac ablation, where they will go to an electrophysiology lab and the electrophysiologist will actually burn a piece of heart tissue containing the abnormal accessory pathway so the electricity cannot be conducted through that pathway. So we had several references throughout the PowerPoint to not treating AFib RVR with adenosine. A patient with an accessory pathway could have serious complications if you did not recognize that it was AFib RVR. In a patient with Wolff Parkinson White and AFib, the problem is the atrial chambers of the heart are firing off with a ton of atrial stimuli. The AV nodal junction typically filters out excess stimuli and only allows the appropriate number of beats through the AV node. However, in Wolff Parkinson White, that filter is gone because of the direct access to the ventricles. The fortunate thing is pediatric patients do not typically develop AFib. In speaking with Aiden's cardiologist, he said it would be about a 1 in a million chance for him to develop AFib and Wolff Parkinson White. These were just numbers off the top of his head, and there's no statistical backing of those numbers. However, it is comforting to know that he feels that it would be extremely unlikely. However, he emphasized that anybody treating him should have therapy pads on prior to medication being administered. Most interventions for AFib RVR include cardioversion with calcium channel blockers, not adenosine with actual calcium channel blockers like Cardizem, IV fluid, and electrical cardioversion. It should be stressed that electrical cardioversion in AFib also brings with it special risks of a clot breaking out of the atria, causing a CVA if the patient has been in the rhythm for a little while and has not been anticoagulated. That being said, it should be reserved only for patients that are rapidly decompensating and EMS is anticipating a cardiac arrest. Since Aiden is on beta blockers, I've included just a little section on how to treat beta blocker overdose if you encounter him and he is symptomatic and bradycardic. The treatment for him would be the same as any symptomatic bradycardic patient of his age. Oxygen to get through the acute phase. If the heart rate is under 60 and he is symptomatic, we would initiate chest compressions. If it is a beta blocker overdose, it can be treated with glucagon, some protocols using 0.05 milligrams per kilogram IV push. Epinephrine can be given at 0.01 milligrams per kilogram IV push, and if that isn't effective, pacing can be performed as well. And this is just Aiden thanking you for taking time to learn what he needs when Mom and Dad calls 911.